here's my case presentation for the Clinical Reasoning Forum. So I have a 46-year-old female. She's a home health nurse, and her examination was on January 31st of this year. Her diagnosis was shoulder sprain, cervical and thoracic strain, and headache. Her chief complaint was left shoulder pain for the past 2 months. The date of her injury happened about 3 years ago when she fell from a ladder that caused the shoulder pain. She did seek therapy and it was relieved. However, just recently, the last 2 months, the pain has come back and she's unsure of what caused the pain to come back. So for her photo score, it's 51.83. Her mean score is a 53, and her fear is elevated. So the body diagram, our P1 is left shoulder pain, throbbing with arm elevation, external rotation, reaching behind her back. It's superficial with a 10 out of 10 pain. Her P2 is neck pain. It's superficial, throbbing, and it's a 3 out of 10. She has not experienced numbness or tingling, and the relationship between the two pains is that P1 is involved with movement, and P2 is just usually at the end of the day and typically results in a headache. So P2 may be a result of the guarding of P1. For the physical examination planning, some of the structures that we are going to consider for P1 is the glenohumeral joint and the acromioclavicular joint. For P2, the intervertebral and the facets. For P1, structures that could refer is the cervical spine and the heart. For P2, lungs and diaphragm. Contractile tissues in the area of P1 are the 4 rotator cuff muscles, the long head of the biceps, the deltoids, the pectoralis major and minor, and the trapezius. For P2, the upper traps, the levator scapulae, and the suboccipitals. Other structures to consider for P1 would be the joint capsule, the subacromial bursa, the subcorticoid bursa, and for P2, the cervical ligaments and the intervertebral joints. My primary and secondary hypotheses for P1 is rotator cuff tear is my primary, and secondary is impingement. For P2, I have come up with a primary hypothesis of mechanical neck pain. Some of the aggravating factors for P1 are shoulder elevation, external rotation, and reaching behind her back. And to ease the pain, just avoiding these motions helps. For P2 aggravating, she is unsure. It usually occurs at the end of the day, so it could be from guarding or from stress. P2 easing factors, she takes Advil as well as ice on her neck. Her sleeping patterns and her 24-hour pattern is that she is unable to sleep at night due to this shoulder pain, and her symptoms occur during movement of her arm throughout the day. She's had this pain for the last 2 months. She is unsure what causes pain to reoccur. She is getting worse, and the history of the fall from the ladder 3 years ago is significant. She did receive prior physical therapy, and it did alleviate her pain. So the red flags that I will want to rule out is a possible myocardial infarction. Based on her intake form, there are no other risk factors indicated that leads me to believe that it is a myocardial infarction besides the pain referral to the neck and the right shoulder. Follow-up questions should be asked to ensure no referral is needed. There's no yellow flags and no tests, and she is currently taking Advil. My asterisk signs for P1 is the 10 out of 10 pain for reaching above her head, reaching in front of her body, as well as behind her back to fasten her bra, as the difficulty sleeping at night due to pain waking her up. P2 is a 3 out of 10 cervical pain at the end of the day. So after the subjective interview, my primary and secondary hypotheses are still the same. I have been unable to rule out any musculoskeletal hypotheses and unable to rule out the cardiovascular problems. But based off the patient's medical history, a possible heart attack seems less likely. However, I should have actually conducted follow-up questions regarding her family history, which I will be sure to do next time. So for the severity of the condition, it is severe. She does have a pain rating of 10 out of 10 at its worst, and she is currently unable to sleep at night due to this pain. The irritability of the condition is minimal. Her symptoms do relieve after 2 to 3 minutes. The nature is musculoskeletal. Her symptoms are getting worse, and she is in an acute stage of a chronic problem. Her symptoms are stable, and they are able to be reproduced with movement. I would want to conduct the full CAN test and the painful arc for rotator cuff pathology. I'm going to do the test item cluster for impingement, which includes Hawkins-Kennedy, painful arc, and infraspinatus manual muscle tests. After I performed these tests, I decided that I am going to defer painful arc and infraspinatus of the test item cluster for impingement, because when conducting the Hawkins-Kennedy test, the patient's pain and her irritability were increased significantly. So there are no precautions or contraindications with this patient. She has no abnormalities in her posture. Functional movement is the pain with overhead reaching on in front of her body and fastening her bra. I did clear the cervical spine. Her neuro exam was within normal limits. With her shoulder range of motion, however, she was only able to get 75% of flexion, abduction, and external rotation, all with pain at this end range. I did not quantify the pain at the end ranges, which I will be sure to do in the future. Her resting pain is 0 out of 10. So with palpation, she was tender to touch on her anterior shoulder. Her joint restriction assessment was limited by pain and will be deferred until next visit. Resisted testing was not performed due to her irritability, but a 3 out of 5 for shoulder flexion, external rotation, and abduction were assessed due to the patient's ability to lift and hold her arm against gravity. Her motor control was normal. In her special tests, she had a positive Hawkins-Kennedy, a positive painful arc, and a negative full CAN test. So based off of the assessment, physical exam, and history, I decided to change my hypothesis to primary impingement. My asterisk items are the 10 out of 10 pain with all the previously mentioned motions and sleeping at night. My physical exam exhibited pain before resistance with flexion greater than 120 degrees, pain before resistance with external rotation greater than 60 degrees, and pain before resistance with abduction greater than 120 degrees for my asterisks. I do expect my patient to have a full recovery. I will see her for 6 weeks, 2 to 3 times a week. For our goals that we just came up with together, the patient will be able to reach overhead pain-free in 4 weeks, be able to fasten her bra pain-free in 6 weeks, and be able to sleep 8 hours without waking due to pain in 3 weeks. I will know if my patient's ready for discharge if she's able to perform these functional tasks without compensatory motion with minimal pain. She will also have to agree that she feels comfortable enough to monitor signs and symptoms independently. If the patient is not making progress, I will decide to stop treatment after I have discussed and or tried all possible strategies of care with this patient. So to manage my patient's care, I'm going to start with managing pain and inflammation using glenohumeral joint mobilizations, grade 1 and 2, manual scapular mobilizations, modalities including IFC and ICE. I will also treat the thoracic joint hypomobility with prone PAs as indicated by the evidence. If there's any questions,